Japanese encephalitis and understream threat. Japanese encephalitis. Economic impact, epidemiology, transmission, clinical sign, diagnosis and treatment, disease in human, prevention and control, action to take. JE Global burden. A disease of public health importance, epidemic potential, high case fatality, complication leading to lifelong sequelae. Previously, disease of East Asia, Japan, Korea, and China. Recent year spread to SEA, Thailand, Indonesia, India, Bangladesh, Vietnam, Myanmar, and Sri Lanka. Estimate 43,000 cases with 11,000 deaths and 9,000 disabilities occurs per globally. The organism nucleocapsid, core protein C, nucleoglycosylate, membrane protein M, non-structural protein NS. Genus Flavivirus, name derived from the Latin flavi means yellow. Single standard enveloped RNA virus. Viral genome 11 kb. Molecular weight 3 into 10 power 6 Dalton. Agglutinates chicks and goose RBC. History 1870s Japan. Summer encephalitis epidemic. 1924 Great Epidemic in Japan. 625 human cases. 397 deaths. 1935 virus first isolated fetal human encephalitis case. 1938 virus isolated from Mosquitoculus trichinorenicus. 1940 to 1978 disease spread with epidemic in China, Korea and India. 1983 immunization in South Korea started as early as age 3. Endemic area started earlier. 1983 to 1987 vaccine available in US on investigation basis. JE in India historical background. 1952 first evidence of JE viral activity by VRC NIV. 1955 first human case of JE. 1956 first viral isolation from mosquito. 1958 first viral isolation from JE case. 1973 first outbreak in Bankura and Burdwan in West Bengal. 1976 repeated outbreak in Burdwan. 1978 several state reported outbreak of JE. 2003 JE prevention and control under integrated NVBDCP. JE endemic area in India. Economic impact porcine high mortality in piglet, equine up to 5% mortality rate, human cost for immunization and medical treatment, vector control measures. Epidemiology, geographical distribution, endemic in temperate and tropical region of Asia. Disease controlled by vaccination. Disease has not occurred in US. Morbidity or mortality. Swine mortality high in piglet, rare in adult. Equine mortality rate less than 5%. Human mortality 5 to 40%. Serious neurological sequelae 45 to 70%. Transmission agent host vector environment. Agent JE is a viral disease and arbovirus flavivirus closely linked antigenically to other flavivirus. Single serotype but geographic strain differ by RNA sequencing. Neurotropic and primarily affected general nervous system. Host J virus is primarily zoonotic in its natural cycle. Natural host animal and bird. Pig amplifier host allow manifold virus multiplication without suffering from disease and maintain prolonged viremia. Cattle and buffaloes mosquito attractants. Man is an accidental dead and host. Usual age group below 15 years with no sex predilection. Vector Culex Tritaniorhynchus C. Vishnavi and C. Pseudo-Vishnavi. Breeding habit irrigated rice field, slow detect and fall etc. Resting habit exophilic but may rest indoor in extreme summer. Feeding habit zoophilic and outdoor as well as indoor feeder. The average life cycle mosquito is about 21 days. Flight range long distance 13 meter. Environment mainly prevalent in rural area. Outbreak is a seasonal phenomena. Mosquito vector prefer large and clean water collection for breeding. Paddy cultivation area offer typically favorable situation. Rural setting offer the amplifier host in abundance. Occurrence in monsoon and post-monsoon season in North India from May-October, in southern part from August to November. How Japanese encephalitis is transmitted. Transmission cycle: pig mosquito pig, bird mosquito bird. Due to prolonged viremia, mosquitoes get opportunity to pick up infection from pig easily. Affect an astringent incubation period of for 9 to 12 days. Infected female mosquito transmit the virus to other host. Man is dead and in transmission cycle due to low and short-lived viremia. Mosquito do not get infection from JE patient. Animal and Japanese encephalitis. Animals and Japanese encephalitis. Incubation period 8 to 10 days. Usually subclinical. Fever, impaired locomotion, stupor, teeth grinding, blindness, coma, death rare. Exposure early in pregnancy more harmful. Birth of stillborn or mummified fetuses. Piglet neurological sign death. Birth. Infertility, swollen testicles. Differential diagnosis: equine WEEE, other viral encephalitides, Hendra rabies, neurotoxic, toxic encephalitis, swine, myxovirus, parainfluenza first, coronavirus, meningale virus, porcine parvovirus, PRS. Clinical diagnosis: clinical horses, fever and CNS disease, swine, high number of stillborn piglets, laboratory test, definitive viral isolation, blood spinal cord, brain CSF, rise in titer, neutralization HIF, CF, ELISA, cross reactivity of flavivirus. Treatment: no effective treatment, supportive care. Japanese encephalitis in human. Clinical manifestation: high ratio of symptoms to asymptomatic infection. Incubation period 6 to 16 days. Course of the disease can be divided into 3 stages. Prodromal stage: acute onset, fever, chills, headache, and malaria, malaria, acute encephalitis stage, high fever 38 to 40.7 degrees Celsius, neck rigidity, photophobia, acute encephalitic stage, acute encephalitic stage, high fever 38 to 40.7 degrees Celsius, neck rigidity, photophobia, nausea, vomiting, seizure, and altered sensorium. Sensorium. Variable neurological signs appear: cranial nerve palsy, tremors, ataxia, abnormal reflexes, paralysis, delirium, and ultimately coma. Late stage and sequelae. Acute inflammation subside neurological sign stable, sequelae Parkinson's, paralysis, and mental retardation. Case fatality rate exceed 25%. Case definition for JE diagnosis and reporting: suspect case acute encephalitis syndrome, febrile illness of variable severity associated with neurological symptoms ranging from headaches to meningitis or encephalitis. Symptoms can include headache, fever, meningeal sign, stupor, disorientation, coma, tremor, paralysis, generalized hypertonia, loss of coordination, patient with fever, altered sensorium lasting more than 6 hours, no skin rash, and other knowing cause of encephalitis excluded. Probable case. Probable case. A suspected case with presumptive laboratory results, detection of an acute phase antiviral antibody response through one of the following: evaluated and stable JE antibody titers in serum throughout ELISA or HI or virus neutralization assay or IgM antibody to the virus in serum. Confirmed case. A suspect case with confirmed laboratory results, detection of JE virus antigen or genome in tissue, blood, or other body fluid by immunochemistry, immunofluorescence, or PCR, or JE virus specific IgM or CSF or fourfold or greater rise in paired sera, acute and convalescent phase through IgM or IgG ELISA, HI or virus neutralization test. Death and disability. Seen in picture is a man raising his child to a hospital in Gorakhpur, Uttar Pradesh. Doctor look at the child who is being treated for Japanese encephalitis at a hospital in Lucknow, India. Diagnosis. Laboratory diagnosis required: tentative diagnosis, antibody titer, HI-IFA, CF, ELISA, JE specific IgM in serum or CSF. Definitive diagnosis: virus isolation, CSF, brain, no specific treatment, supportive care. Mainly sympathetic and supportive therapeutic norms of the suppurative therapy are not established. Fluid and electrolyte balance, reduction of intracranial pressure, control of convolution if present, maintenance of airway is crucial. Prevention and control of JE, early diagnosis and proper management of JE cases, strengthening of preferred mechanism, integrated vector management, insecticide residual spray not recommended, reduction of breeding source, water management system with intermittent irrigation system, incorporation of neem product in rice fields, anti larval operation wherever feasible, larvivorous fish, biolarvicides, fogging with malathion for immediate killing of mosquito during outbreak, reduction in main vector contact, personal protection with ITNS, repellent protein etc. and exploring possibility of segregation of pig, mosquito proofing of piggeries, behavioral changes, communication for community participation and intersection intersectorial conveyance, capacity building through training on case management and control of GE, vaccination of children in JE endemic area 1 and 50 year, operational research, monitoring and evaluation, vaccination, live attenuated vaccine, equine and swine, successful for reducing incidence inactivated vaccine JEVAX, Oman, Japan, Korea, Taiwan, India, Thailand, used for endemic or epidemic area, travelers, military laboratory workers. Not an outbreak response vaccine, universal vaccine for JE endemic area. All children from 1 to 50 years should be vaccinated. Philippines studies show acceptable efficacy when co-administered with measles vaccine at 9 months. Travelers vaccine in JE endemic area when expected to stay for 4 weeks and should complete the dosage prior to 1 week before travel. JE vaccine 3 type produced and used worldwide. Inactivated mouse brain vaccine India Nakama strain 0.51 ml SC 2 dose 1 to 4 week apart, booster after 1 year, subsequent booster at 1 3 year interval. Inactivated hamster kidney cell vaccine, low attenuated hamster kidney cell vaccine. JE vaccine, JE vaccine, inactivated mouse brain vaccine. It is expensive vaccine, complicated dosing schedule, side effect of this vaccine. Inactivated mouse brain vaccine, $35 per dose, $95 per child. The mouse brain vaccine manufactured by killing population of mice was being manufactured by Central Research Institute Kasholi. Live attenuated vaccine SA 4242 Chinese live attenuated vaccine at affordable cost, safe, effective. This vaccine was developed in China and has been used there since 1988. It has been licensed and used in South Korea and Nepal and licensed in Sri Lanka. Gaps and challenges of the prevention and control of JE, outdoor habit of the vector, variation in vector bionomics, scattered distribution of cases spread over relatively large area, role of different reservoir hosts, specific vector for different geographical and ecological area. Immune status for various population group is not known, making it difficult to delineate vulnerable population group. Gap and challenges of the prevention and control of JE. Difficulties in segregation of peaks, inadequate surveillance, efficient rapid diagnostic for field use not available, inadequate epidemic forecasting and preparedness, lack of supervision and monitoring, limited intersectoral con- convergence and community participation. JU immunization program, supply of vaccine and cold chain agreements, cost factor coverage. National Vector Borne Disease Control Program. Vision: a well-informed and self-sustained healthy India free from vector-borne disease with equitable access to quality health care. Mission: integrated and accelerated action towards reducing mortality on account of malaria, Japanese encephalitis, dengue by half, and elimination of Kala-Jar by 2010, and elimination of lymphatic filariasis by 2015. Thank you.